is Dr. Gaurang. He will speak on peripheral retinal degenerations, when, what, and how to treat.
Good afternoon, everyone. I'd like to thank AIOS for giving me this opportunity. Today, I'm going to speak on peripheral retinal degenerations, when, what, and how to treat. So the presentation plan is going to go in 3 parts. In part 1, I will describe the peripheral retinal degenerations which we have. In part 2, I'll like to elaborate when to treat, and the last part would be recommendations for patients who are undergoing any refractive or cataract surgery. So part 1, the different peripheral retinal degenerations. So first of all, we have to understand what do we mean by degeneration. Degeneration means loss of structure or function of a cell in a tissue or organ anywhere in the body. And when this loss of structure or function is happening in the retina, we call it as a retinal degeneration. Now these retinal degeneration can either be on the posterior pole or in the periphery. If it's on the posterior pole, it is commonly seen in macular degeneration such as ARMD. Now classification based on location, the degeneration can be either vitreoretinal, intraretinal or chorioretinal. Snail track, lattice and retinal tears are vitreoretinal. Retinoschisis, snowflake, WWOP, DWOP, atrophic retinal hole with or without operculum are intraretinal, whereas paving stone degenerations and peripheral occlusions are chorioretinal degenerations. Now, why are they important? Because usually they are located anterior to the equator, they can be easily missed, can be associated with atrophic retinal breaks and can develop dynamic retinal tears which can lead to RDs, and of course all of them predispose a person to rheumatogenic RDs. Now the common ones are, the first is a snail track degeneration. Now this looks very similar to what a lattice looks like because it is of the same size, shape, orientation and location as the lattice. It can also be associated with a retinal hole. Now I have ran a OCT through the degeneration of, which is the snail track 1, and if you can see here, there are irregular retinal surface and you can see hyper-reflective dots on the OCT which are basically lipid deposits. Whereas irregular retinal surface also you can see in the OCT, and if you can see the scan, there's an atrophic retinal hole with a bit of SRF, and the surrounding retina is also very atrophic. So this is OCT which is going through the lesion. So the vitreous changes in a snail track degeneration are the vitreous liquefaction noted, and there is no dense vitreoretinal adhesion which is seen. So this is how we basically differentiate. Second is the lattice degeneration. So a lattice degeneration is basically present in periphery. It can be superior temporal, superior nasal, any part of the retina it can be seen in. The third is a retinal hole. A retinal hole is a small hole. It can be present. It is total loss of structure. The whole retina is missing. So it can or cannot be associated with the operculum. Usually we see a retinal hole with the operculum. It can be atrophic also. Now third part is a dynamic part which I'm talking about. That is a retinal tear or a horseshoe tape tear. If you can see, this is basically when the PVD induces from the posterior pole and goes towards the periphery. It's a dynamic break, it's not a static break. So the vitreous pulls and causes a horseshoe tape in the periphery, again predisposing for retinal detachment. Third is a snowflake degeneration, the next one. The snowflake, these are white crystal deposits, which are crystal-like deposits which are seen in the periphery. Paving stone degeneration is a type of chorioretinal degenerations, again seen in periphery. These are basically chorioretinal degenerations, as I told in starting of my talk. Now there's something called as WWOP, which we call white without pressure. So if you can see in the temporal periphery, there's a region of whiteness which is present, beautifully captured on the ultraviolet imaging. Now there's something which is called as a dark without pressure. Now these are dark areas on the retina. WWOP are white areas on the retina, and DWP are dark areas on the retina. Without pressure means that these lesions are seen without indentation, without applying any external pressure to the globe. Now what causes a RD in an eye with peripheral retinal degenerations? Basically, it is a posterior vitreous detachment. Unless the vitreous is well formed, there is no posterior vitreous detachment, the risk of RD is pretty low. But once the retinal PVD has happened, of course, there is a very high risk for retinal detachment. Now, there's an acute if there's acute symptomatic PVD, there's acute onset of flashes and floaters, which can be seen. And usually patient comes to us that suddenly I'm seeing so many floaters in front of my eyes. Now, acute PVD can be associated with either vitreous hemorrhage, retinal tear, or an RD. Repeat retinal examination. Once the patient walks into your clinic and says that he or she is having floaters, and you make a diagnosis that the PVD has started, you should again examine after 4 to 6 weeks. So there's to make sure that the PVD has happened uneventfully and has not left a mark in the eye. Now, when to treat? So first you have to see what is the lesion and what are the vitreous changes surrounding the lesion and what are the risk factors in the patient developing for an RD. Now the recommendations for screening and management, do we treat all the lesions, all the 8 lesions, 9 lesions I talk about, do we treat all of them? No, that's not the case. So this is I've taken up from AIO. Basically it's more on the Western data. We are still lacking a study on Indian data, which basically says that all symptomatic and asymptomatic horseshoe tape tear, HSTs, operculated holes, lattice degeneration with holes and atrophic holes is treat promptly. So anything which has a hole, anywhere where the retina is missing, you have to treat. If it's HST, you have to treat. All symptomatic lattice degeneration without holes, treatment is usually recommended. So I was saying you can treat if you want, it's the surgeon's choice. All asymptomatic lattice degeneration without holes, pigmented lattice degeneration and atrophic holes, they can be observed. Whereas eye with atrophic hole or lattice degeneration where the fellow eye has already developed retinal detachment, is better that we treat asymptomatic lesions in the other eye also. Now we have our refractive colleagues and our cataract colleagues who usually refer us for peripheral retinal examination. So once you have spotted out there's a peripheral retinal degeneration which has to be treated like with a hole or a HST, then I would recommend that you do a barrage laser and wait at least 7 to 14 days following the laser photocoagulation, and then you go and plan a refractive surgery. I strongly recommend that there should be retinal re-examination as early as 2 weeks for the surgery to make sure that the laser marks are taken up well and there is no risk of retinal detachment in future. So the take-home message is that patient undergoing cataract or refractive surgery, please look for periphery. Prophylactic barrage photocoagulation is the way to the predisposing degenerative retinal lesions at least a week before the surgery. Retinal examination should be done at regular intervals. Development or progression of PVD, retinal tears, RD, and macular pathologies is very less documented. Thank you.
Yes.
Very nice talk, thank you. But few points I think will differ that detachment is associated with the vitreous condition, not the PVD. Because lots of times we will get detachment with atrophic breaks, no tear. And we have to induce the PVD while doing surgery. Number one. Number two is that all holes we don't laser. AO is not recommending that till the latest things. All symptomatic tears and asymptomatic tears also they are telling laser, horseshoe tears. But all holes, the peripheral holes, asymptomatic holes, by chance you are on examination, you are diagnosing, they are not recommending laser.
They are saying it depends upon this can be treated. This is what they have said for
And
atrophic holes.
Not needed clearly. And number two is there's some areas where you can treat, like the aphakia is there, and the other eye detachment on some vitreoretinal degenerations are there. And another thing you did not mention, FEVR. So those areas you have.
Even for GRT, if one eye has developed a GRT, we usually go and do laser for the other eye also.
Where you will laser? In GRT, one eye you get laser.
Other eye, if there are asymptomatic degenerations. That has also been recommended, yeah.
Sir, all cataracts also don't need treatment, they're being treated. So it's better to treat a retinal hole rather than treat an 6-9 cataract.
Thank you.